The deltoid injection site is easy to access, and it is also easy to locate. It is suggested that the deltoid is a better site than the gluteal muscle for small volumes and rapid onset injections because the deltoid has the greatest blood flow of any muscle routinely used for IM injections. A disadvantage to the deltoid injection site is that pain appears to be one of the most frequently reported complications associated with this site. Proper landmarking is essential in order to avoid substantial injuries. For men and women under 90 kilograms or 200 pounds, a 1-inch needle is appropriate for an intramuscular injection. For men and women over 90 kilograms or 200 pounds, a 1.5-inch needle would be required to achieve intramuscular injection. In patients over the age of 65, the deltoid muscle atrophies while the fat pad thickens, meaning a longer needle is necessary. Like other IM injections into the deltoid muscle should be given into the densest part of the muscle at an angle of 90 degrees. However, its relatively small mass, close proximity of the radial nerve, brachial artery, and bony processes make proper landmarking of this site essential. Find the acromion process as the upper marker, then locate the axilla, otherwise known as the armpit, as the lower marker. Draw an imaginary triangle pointing downward from the acromion, or draw a rectangle in the middle third of this area. The injection site is in the center of this area, or the point halfway between the markers. It will be from 1 to 4 finger widths from the acromion, depending on the size of the arm. The injection should be given at or immediately below the midpoint of the muscle and should never be given below the level of the axilla. As for bunching versus flattening, the WHO immunization guide recommends bunching for deltoid injections in patients over 15 months. The use of bunching can affect the deltoid fat pad and skin-to-muscle ratio, and therefore the required needle length. As well, since it is the skin and subcutaneous layers which are raised with bunching, injections with older adults may result in inadvertent subcutaneous injections, particularly in females with body mass index greater than 35. Therefore, refer to the Z-track technique. The patient should be sitting, but it could be done while standing. Deltoid injections should be alternated between the two deltoid muscles. It is recommended that nurses use the Z-track technique for all IM injections, although it is not strictly necessary. The Z-track technique has been shown to be effective in decreasing leakage through the subcutaneous tissue. In order to make use of the Z-track technique, the nurse should use their non-dominant practitioner's hand to pull the skin and subcutaneous tissue 1 to 1.5 inches to one side of the injection site prior to injecting. This creates a disjoint perforation or broken injected pathway that locks the medication into the target muscle, preventing flowback.